Thank you. Nihaal, we can start.
Okay. Yeah, so that's the format. We have 12 cases for today. Me or one of the fellows will be going into the clinical and imaging details. We'll give our thoughts on each case, and we'll open the case for comments from the panelists. So going on to the first case, I would like Geeta to present the case if she's there.
Yes, sir, I'm there, sir. So this baby is a female child at 50 days of life, present to us, born full-term to non-consanguineous parents, and there was a history of birth asphyxia and neonatal seizures on the day one, and irritability was there from the day one onwards. It was persistent every day, and there were some feeding issues, sir. And had jaundice requiring the transfusions, and in view of excessive irritability and non-consolable cry, baby was referred to here. Head circumference was relative microcephaly was there, and there was coronal suture overriding was present. Examination, and there was generalized spasticity with the cortical thumb was present.
Okay.
And investigations wise,
yeah. I'll show the images first, then we can go with the investigations.
Yes.
So at this point, any clinical possibilities we were thinking of?
We were thinking of the perinatal asphyxia, some more of the perinatal issues.
Oh. Okay.
But there was a coronal suture overriding, which is like unusual, which may point towards the antenatal insult and such severe microcephaly also, sirs.
Okay. So I have only external films. On top is the FLAIR axial sequences. And here you can appreciate there is extensive multicystic encephalomalacia involving the bilateral cerebral hemispheres. Also in the subinsular regions. What you can appreciate is that the deep gray nuclei are relatively spared, that is the basal ganglia is spared, whereas the thalamus demonstrates some areas of signal changes. There is also bilateral asymmetrical subdural extraxal collections on both sides. If you go see on the top panel on the axials, the cerebellum and the brainstem are relatively spared in comparison to the supratemporal brain parenchyma. The DWI is not very optimal, so I don't think we can commit much, but the parenchymal, there's no certain areas of restricted diffusion in the parenchyma, but the images, the film is not optimal. Then I have the sagittal images. As you can appreciate, there is a diffuse thinning of the corpus callosum. But if you see the brainstem and the cerebellum, they are relatively spared in comparison to the supratemporal brain parenchyma. So overall, a multicystic encephalomalacic pattern predominantly involving the white matter. The basal ganglia are relatively spared. Posterior fossa structures are also relatively spared with subdural collections on both sides. So at this point, Geeta.
So TMS was showing mild elevation of ornithine and urine organic acid, like elevation of uracil, but they were not very much indicative, significantly elevated. Ammonia also mild elevation, so we can take it as like more of a normal thing. And because the child had multiple transfusions and jaundice, any hepatic impairment we can think, but INR is normal. And EEG wise, there was only diffuse cerebral dysfunction and no clinical seizures as such, except for the day one.
Okay.
So our question is whether any genetic, genetic causes, or per se it is due to the perinatal or antenatal insult are these changes.
Yeah. So at least on the imaging findings, some pointers which you try to use to differentiate between HII and the HI mimic. The newborns in HI ischemic injury usually stabilize within 1 to 2 weeks, whereas the genetic disorders such as the molybdenum cofactor sulfur oxidase usually do not show any improvement or stability. The caudate nucleus and the globus pallidus is relatively less commonly involved in a hypoxic ischemic injury, whereas they are more commonly involved in the molybdenum cofactor sulfur oxidase spectrum disorders. Posterior fossa is relatively normal in comparison to supratemporal structures, whereas it can be hypoplastic in the HI mimics. Spectroscopy, because of the anaerobic metabolism, can demonstrate lactate peaks in both, but there are also some peaks which, such as taurine and sulfocysteine, which can be seen on the short echo. and helpful in diagnosis of these disorders. This is just an example of molybdenum cofactor deficiency. As you can see, there are multicystic encephalomalacia pattern appearance predominantly in the peripheral areas of the brain. But if you see, the basal ganglia is abnormal in almost all the cases. So the basal ganglia is a clue. The clinical progression also is a clue. Posterior fossa involvement is also another clue. So at least what I'm thinking is that the changes are a result of sequelae of antenatal or perinatal insult. At this moment, I'll open the case for any further comments.
Can I make a brief comment? Do you hear me?
Yes, I can. Please go ahead.
I think, as you have said, this is a generalized encephalomalacia, and typically the cerebellum is spared. For me, this constellation is a straightforward acquired condition, and I would not spend any money on metabolic and genetic investigations. And because you have this amount of volume loss, you have extracerebral fluid compartments, and this also explains the overriding of the sutures, which also means you have a subsequent loss of tissue. This is also common in Zika infection, which of course is not under discussion here. So this is, I think, an acquired condition.
Yes, I think I also agree. This pattern looks very much acquired, but just as a matter of interest, did they do a uric acid level? Like if they were suspecting sulfite oxidase? They didn't mention it.
Geeta?
We didn't do, ma'am.
Okay, it's okay.
Okay, right. Thank you. Moving on to our next case. Case 2 is from Dr. Ramesh. If Surbhi is there, she wants to pick it up, or I can do it. Okay, I'll go ahead with the presentation. So this was a 2-month-old child presented with acute encephalopathy and respiratory failure and had cardiac dysfunction. Child also had failure to thrive with extrapyramidal signs. The blood lactate was elevated at 13.1 with metabolic acidosis on admission. Within 4 hours, I think the lactate, the repeat lactate was done, which came out to be 2.1. I'm not sure if someone can confirm if it was CSF or blood lactate. TMS demonstrated elevated carnitine, but this was post-IV carnitine sample. The rest of the metabolites in the TMS demonstrate normal appearance. The urine GCMS was inconclusive, and vitamin B12 demonstrated slight changes, was slightly lower on the lower side. If Dr. Ramesh is there, if he wants to add anything to the presentation, or on the fellows with Dr. Ramesh. Okay, I'll go ahead with the imaging findings. So we got an MRI done, and here on the top panel you can see the T2 axial images. We have these symmetrical areas of cortical signal changes in the perioronic regions and also in the cingulate cortex. Coming lower down, the insular cortex also demonstrates hyperintense signal changes. Bilateral signal changes or symmetrical changes in the mid and posterior putamen, also involving the periaqueductal region along the third ventricle and the brainstem. The middle cerebral peduncles also demonstrate hyperintense signal changes. Similar changes, corresponding changes are demonstrated on the flare. Again, cortical hyperintensities, symmetrical changes in the dorsal striatum, the periaqueductal gray matter, and areas of restricted diffusion on DWS sequences. Spectroscopy was done. We could not appreciate any lactate peak. The rest of the peaks demonstrated as normal appearance. So based on the imaging findings and the association of cardiac dysfunction, at least on the imaging, the neurological findings could be attributed to thymine transporter deficiencies. This was actually published last year by Vanishing et al. Dr. Ramesh et al. Again, these have typical changes of involvement of the cortex, the dorsal striatum, periaqueductal gray matter, and also the cerebellar structures. The differentials to be considered is a primary mitochondrial disorder, which can translate into a Leigh syndrome phenotype. So I don't know if you have a follow-up or any lab investigations to confirm the diagnosis. So at this time, I'll open the case for discussion.
Do you also think of a nutritional thymine deficiency in such a, just a thought? They can also have cardiac dysfunction and
yes, ma'am. So something
Most of
related
these
to the
cases
thiamine pathway. Yeah.
See only nutritional, predominantly breastfed, but most of the children, what we see is around 4 months to 6 months, sometimes up to 9 months of age. This child is quite young, and many of them have significant cardiac dysfunction, pulmonary arterial hypertension as the initial manifestation. And the distribution of lesions are almost like similar to this pattern, but it is a one-time insult, and the thiamine levels, most of the times the pediatricians are quite aware of this condition, and they tend to use the thiamine quite early in the illness. So you may not be able to do the child's thiamine level, but maternal thiamine level sometimes is a surrogate marker to say there is a thiamine deficiency. And predominantly, most of them are exclusively breastfed infants.
Okay.
There are no further comments. I'll move on to our next case. Case is from Dr. Lokesh. If Dashrath wants to present the case.
Yes. This is 8-year-old male child, normal development, born to non-conforming parents, presented with vomitings and headache on 28th of December 2021, which was gradually increasing in intensity, for which a child underwent lumbar puncture, which showed neutrophil predominant leukocytosis, and 4 to 5 RBCs were there. So started on higher end antibiotics, and MRI was done. So MRI was showing a left lateral ventricle bleed. So to evaluate for that bleed, even though child clinically improved after starting on anti-edema measures and antibiotics, child underwent CT angiography, which was showing bleeding in the basilar artery, and even in the proximal end of the middle cerebral arteries. Then gradually child sensorium got deteriorated and developed right hemiparesis with a deteriorating sensorium. Then repeated MRI brain and MR angiography on
Yeah, Dashrath, do you want me to?
Showing left side AC-MCA border zone infarct with multiple right frontal subcortical punctate infarcts, and the MRA is showing the proximal stenotic lesion on the bilateral MCA arteries. So
at this point, thinking of anything?
So at this point, in the presence of bleed and followed by even bleeding structure in the posterior arteries, vasculitis was thought of, either infective or inflammatory. So started on methylprednisolone pulse therapy and IVIC. CSF was also repeated, which got normalized. Actually, previously it was 144 cells with 90% neutrophils. Now only 10 cells, all are lymphocytes. The proteins and sugar were normalized.
Okay.
So even after methylprednisolone pulse therapy and IVIC, child sensorium progressively deteriorating. So for further management, got referred to Rainbow Children's Hospital, Hyderabad. So in view of encephalopathy with a bleeding in intracranial vessels, we thought of inflammatory vasculitis. So evaluated further to see whether there is any systemic involvement. So ESR was 70, 2-day echo was showing mitral valve prolapse and left anterior descending coronary artery dilatation, which was significant. And urine routine was showing 70 to 80 RBCs, and protein creatinine ratio is elevated, 3.5. It is in the nephrotic range of proteinuria. And C3, C4 were normal, C ANCA, P ANCA were normal. ANA panel complete profile is normal. And to see for infective etiology of vasculitis, HIV, HPCAC, and SCV worsened, which were normal. So during course of illness, within 3-4 days after admission, child is having increasing left decorticate posturing, with a decreasing facial grimace to painful stimulus. So then we got MRI repeated.
Yeah, go ahead, Darshan.
Yes, which was showing bilateral frontoparietal and temporal diffusion restriction with the involvement of right caudate and putamen cytotoxic edema. So we can see the ADC reversal, and on SWA you can see bouquet of hemorrhages in the cerebral white matter. Even a radiating blooming we can see. And in contrast, so the lesions were there is leptomeningeal enhancement more on the left, more on the right side. So on MR angio, we can see the same stenotic lesion on bilateral proximal posterior cerebral artery, and left side MCA is less visualized. And on contrast enhancement, we can see the bilateral internal carotid vessel wall is getting enhanced. This is without contrast, and this is with contrast. You can see the contrast enhancement of the vessel wall. So with deteriorating the sensorium and progressive CNS lesions, we went ahead with a third immunomodulation, like single volume plasmapheresis we started, 8 cycles we have given total, and 1 dose of cyclophosphamide was given, and 2 doses of rituximab was given. So after 8 cycles of plasmapheresis, 1 dose of cyclophosphamide, we repeated ESR, which was 18. Previously it was 72, and protein creatinine ratio also reduced from 3.5 to 2.2. In between, renal biopsy was done for the child. The report was normal, and there is no progression of coronary artery dilatation, which got stabilized, and LV dysfunction also improved.
So at this time, you're thinking of cerebral CNS vasculitis? Yeah.
Yes. But involvement of coronary artery dilatation and hematuria, nephrotic range proteinuria could not be explained with pure primary CNS vasculitis.
Okay. So medium and small vessel vasculitis is a possibility?
Yes.
Okay, and also patient has hypertension, I think, or
slightly involved, I think, but the large vessels were normal.
Yeah.
The thorax, but I think the ICA was involved, and along with that, medial cerebral artery.
Yeah. So just to give you the examples of CNS vasculitis, they can present on the angio with biliary appearance, and multifocal infarcts can be demonstrated. Can also present with microhemorrhagic foci. They can be focal and they can also be extensive. I think this patient also had COVID, no? That's right?
Yes, sir.
COVID after admission.
After admission.
So just to put it out there, that COVID can also cause these infarct-like lesions and also microhemorrhagic foci, and this vasculitis pattern can also be seen. So at this point, I'll open the case for further comments.
Vasculitis workup was negative. ANA panel, ANCA, P ANCA, C ANCA was negative. And we are hoping to get some information on the brain biopsy, kidney biopsy, which was negative. I think the last MRI, I think it was not shared. The contrast enhancement had significantly increased. Was not increased, but the contrast enhancement was much more. Do we have that image?
I don't think no. But that can be explained by the ischemic lesion because of the luxury perfusion. There was more chiral enhancement than leptomeningeal enhancement, is what I remember.
He is extubated, he is breathing spontaneously, he is recognizing family, and but he is in that sort of decorticate posturing most of the times, requiring botulinum toxin injections for bilateral biceps and brachioradialis. So diagnostically, working diagnosis obviously is a medium size, predominantly a medium size vessel vasculitis, which is systemic in nature. We have sent mutations for the genetic vasculitic syndromes, including DADA2 and other things, which will be probably available in a week's time. So that is another differential which was considered along with discussion with our rheumatologist.
Dr. Lokesh, there's a question from the audience if icardiguanidase needs to be considered for this. I don't.
Child was developmentally completely normal. Eye examination is normal, and it came on all of a sudden with the bleed, no calcifications anywhere.
Yeah.
And I'm not sure this kind of pattern is described, although vasculopathies are known. Yeah.
Yeah.
So I think vasculitis definitely, I think there's no doubt about it. I just wanted to ask, is there a past history of COVID infection? Did you do a COVID serology as well? Because many of these multi-system inflammatory cases came up after COVID infection in children. Because you said COVID developed in hospital after admission, but was there a past history as well? Like,
Swasni, was in two different hospitals. Yeah, sorry, antibodies?
Negative, okay. Negative. Okay.
HBsAg were also done for infective predisposition to vasculitis. They were also negative.
Okay.
We did most of it, but that was one thing.
Yeah. Yeah, I think I don't want to add anything. I think it was a difficult case.
Yeah. Okay, let's hope we can get an answer on the genetics of this. Moving on to our next case is from Kirti. Kirti, if you're here, you can take over. Okay, Kirti is not there. I'll go ahead. So this was a 3-year-old boy born to second-degree consanguinity, had no perinatal issues. There was a seizure onset at the age of 2.5 years. Total of 6 episodes of seizures were demonstrated with focal with impaired awareness. There was brief loss of consciousness with upholding of the eyes and throat clearing. Developmental-wise, the child was normal. Head circumference was 49 centimeters. There was normal neurological examination. EEG demonstrated occasional left centrotemporal spike and wave discharges. Moving on to the MR findings. On the T2 axial images on top, you can appreciate that there was confluent diffuse white matter changes involving the bilateral cerebral hemispheres. There's relative sparing of the corpus callosum, but the periventricular and almost the subcortical region is involved. The posterior fossa structures do not demonstrate any abnormal signal changes. I cannot appreciate any cortical malformations in the cerebral cortex. Similar changes are appreciated on the FLAIR. There's no rarefaction, but diffusely hyperintense changes on the FLAIR scans. Post contrast was done. There is no enhancement per se of the abnormal white matter regions. At this point, I think the differential, at least radiologically, is wide, but I would concentrate on maybe on the diffuse cerebral or the periventricular predominance pattern. I'm not sure if CPK was done to see if Myelination deficient can be said, but I think there was no tone issues or muscle weakness. But the other differentials to consider are on the table. So I don't know if the question was from Kirti, at least what she communicated was, given these abnormal white matter changes, what is the possibility that the child is normal, and how can you explain that the extensive confluent changes with normal neurodevelopment? So we are thinking of genetic leukodystrophy type pattern, but I think the clinical question was the normal development given these changes.
Brief comment. When you go back to your table, your differential. Yeah, okay. On the very on the column on the very left, you see the IF2B related disorder, which is vanishing white matter disease. For me, this top on the list. and I've seen patients at this age in the first decade who have this appearance. The MR was done because of a seizure, and their neurological condition is for quite a long time is normal. So this would be for me high on the list. From the imaging pattern, also LAMA2 mutation is possible, mentioned there on the third place, but this is a congenital muscular dystrophy and the clinical pattern does not fit at all.
Yeah, some of the leukodystrophies, especially something like MLC1, can have very minimal findings initially on examination. They can develop a mild spastic typology over a period of time. Otherwise, cognitively, they can be relatively quite normal school going. So I think just a normal neurological examination in the initial phase of leukodystrophies may not be an indicator of a benign pathology.
Nihaal, do you have diffusion restriction on MRI?
No, there was no diffusion restriction.
Can you have vanishing white matter with normal diffusion?
Little less likely. I'm also thinking there will be some areas of rarefaction, at least for the cases which I have seen, but I don't think so. Slightly atypical, but since Eigen says it's possible, I think he has seen a few cases. The rarefaction and diffusion changes are expected, but that can be due to in the acute metabolic decompensation phase.
Next step would be genetic testing if not already done.
Okay. I think we don't have PT, but I'll let her know. Yeah, thank you. No further comments. We'll move on to the next case. This is from Dr. Vivek. Dr. Vivek, if you want to.
So this is a 1.5-year-old baby who had a normal birth, few days of neonatal jaundice, nothing significant. But he was noted to have bilateral cataract within few weeks after birth when he was admitted for the first time to the hospital with frequent seizures, tonic seizures, and later myoclonus as well, independently. Liver function was, so there was no organomegaly. The liver was just like a normal baby, so didn't have a large liver. Liver function was normal. Galactosemia screen was negative. Then there was a history. It's a consanguineous relationship, second child, and a sibling had died with similar history, seizures and cataract at 4.5-month age in the past. So that was the history.
Okay.
Can I have a question?
Yeah.
Yes, do you know whether she had also bilateral cataract, and is there perhaps imaging available?
So yeah, she did have bilateral cataract with seizures, but we didn't have a imaging for her.
Thank you.
She was admitted in acute. She had seizures, frequent seizures pre-terminally, and they couldn't do any imaging for her. And at that time, again, they found out she had cataract.
Thanks.
Okay, thank you. So this is day 45, and on the top you can appreciate that is diffuse abnormal white matter changes in the cerebral hemisphere on both sides. The periventricular subcortical white matter also, subcortical is slightly difficult to comment because of the unmyelinated brain, but the central white matter also demonstrates these high signal changes. Temporal lobes, if you can appreciate, there is some differential T2 hyperintensity more along the temporal poles. So that cannot appreciate any posterior fossa changes. Brainstem appears normal, corpus callosum is normal for the age. No blooming foci and SWI. On the FLAIR images, the abnormal white matter demonstrates these refractory changes with some areas of subcortical cyst development in the frontal and parietal regions. And also, if you appreciate on the temporal regions, there is also refractory changes and early cystic development along the temporal poles on both sides. The T1 changes also demonstrate the corresponding hypointensive signal changes of the abnormal white matter. I don't see any abnormality in the basal ganglia or the thalamus. The persistent cavum septum is a normal variant at this age. No cortical malformations or myelination disorders. The lens are visible, but not opacified, but I would not rely on the MRI for diagnosis of cataract. So at this point, at least on the clinical findings for cataract in the newborn and early childhood period, I think the differentials are covered, and the first possibility was galactosemia, which has been ruled out. Given the refractory changes in the temporal lobe, Dr. Vivek, was the child normocephalic or microcephalic?
The child was microcephalic, so but not as below 3 standard, so maybe small head, 2 standard deviation.
Okay. So these are few differentials only on the imaging, the acadic Guterres and CMV, but there is no calcification, no deep brain nuclear calcification or hemorrhage for acadic Guterres also. That actually reminded us of one of our cases from Dr. Ramesh. This was a child with neonatal presentation of vanishing white matter. As you can see, there is diffuse swollen appearance of the brain. If I'm not mistaken, I think vanishing white matter can also have cataracts, though not common, but I've at least seen few papers mentioning vanishing white matter as having cataracts. The other possibility based on the refractory changes was the MLC or the megalencephaly leukoencephalus, but given the microcephalic brain, I think this can be ruled out. The possibility of hypomyelination with congenital cataracts was raised, but I think the white matter changes are more of a swollen appearance rather than a hypomyelinating pattern, as they show rarefaction and cystic changes in the subcortical regions. So this is an image example of hypomyelination. You can see that the flare also demonstrates these high signal changes, whereas in our case, it is at least demonstrating the almost signals closer to the CSF signals. So it is little atypical for hypomyelination. I would probably think of its conditions causing these refractory changes in the subcortical regions and white matter refractory changes.
Can I
at this point, I'll open it. Yeah.
Hypomyelination with congenital cataract has a completely different dynamic compared to this family and the sister who died at the age of about 4 months. This image here is in fact a historic MR from my hospital with prenatal onset vanishing white matter disease, genetically proven, with bilateral cataract. This is, I think, high on the list. And the other conditions you have shown, like Icardis Gouttiere and CMV and so on, I don't think they have congenital cataract.
Yeah, no, just based on the temporal lobes, this was one of the features.
Thanks, that was useful. That was very useful.
So there are no further comments.
Just wanted to ask, is there hypomyelination as well? Because the plic is not, so is a 2.5 month old?
I would say, yeah, there is some degree of delayed myelination. It could be, right. But if I refer to the periventricular subcortical white matter demonstrates these refractory changes. It is not typical for a hypomyelinating pattern.
Right. Thank you.
Okay. Okay, we'll move on to our next case if there are no further comments. Yeah, case 6. So Dr. Ramesh, if one of the fellows wants to take up and describe the clinical findings. Bharat or Geeta or Subhi? Okay, I'll just give you the outlay. It's a 1 year, 44-month child with global developmental delay, dysmorphism, cerebral visual impairment with mild spasticity. Dr. Lokesh, if you want to comment on the images of the patient.
So the significant alopecia.
Yeah.
And a protruded and large tongue.
Okay.
With a prominent large great toe when compared to other toes.
Okay.
Difficult.
So alopecia, facial dysmorphism, protruding tongue, large great toe. Are they fetal pads? Can be seen on these images.
Yeah.
Okay.
And difficult to make out.
Yeah. Okay. Okay. Sure. So this is the imaging done. We have the axle, the T2 on top. Supratentorial vein parenchyma. Cannot appreciate any abnormality. No malformation, no focal lesions. The deep brain nuclei are normal, but you can clearly appreciate that there is some degree of volume loss in the posterior fossa, that is cerebellum, in comparison to supratentorial vein, widening of the interfolial spaces, which can also be seen on the sagittal images. There is some degree of inferior verminal hyperplasia, and there's so overall an isolated finding of cerebellar atrophy. I cannot appreciate any hyperintense cortical changes in the abnormal cerebellum, which can probably narrow down the diagnosis. But based on the imaging, I would say that there is isolated cerebellar atrophy. So just to point out, the finding is a little non-specific, but if one wants to review these conditions, there are two seminal papers from Dr. Bolthauser et al. And here is a pattern recognition approach of pure cerebellar atrophy and cerebellar atrophy associated with other findings in the brain. So this child was sent for genetics, and it came out to be a variant of uncertain significance for CACNA A1G, which causes spinocerebellar attacks of 42. So as it is a variant of uncertain significance, but the clinical and the imaging phenotype is slightly correlating with what is seen in our index case. So they have these facial dysmorphic changes, abnormal hands and toes, and also demonstrate cerebellar atrophy, isolated cerebellar atrophy. So at this point, I'll open the case for discussion if anyone has seen such a mutation in one of their patients.
I was thinking a clinical and imaging differential could also be congenital disorder of glycosylation, because they also have these abnormal fingertip pads, some dysmorphism, cerebellar atrophy. So, but I think you've got a genetic diagnosis. Very difficult to suspect clinically, I think.
Yeah, it was, yeah.
True. Clinically, we would have suspected CDG definitely.
Again, do you want to comment on the cerebellum and the findings, since it's your area of interest?
It's non-specific, not diagnostic, not very helpful. Of course, it's a real finding, but doesn't really help very much.
Okay.
So you had studied all the literature. Sorry, I have not. So the dysmorphism and the alopecia is fitting to that genetic condition.
Yeah, it is.
Am I correct?
Yeah, you're correct. Yeah.
And what is the explanation for the visual impairment, the cerebral visual impairment?
That I'm not sure.
Many of these children with any cause of either genetic or acquired causes of severe diffuse encephalopathy, they tend to have significant visual impairment, cerebral visual impairment as part of the encephalopathy, Professor.
Okay.
Okay, thank you. Next case, Dashak, do you want to?
3-year-old child
Yeah.
who had a congenital hydrocephalus, for which I operated for a VP shunt at 3 months of age. Then gradually increasing head size, now presented for increasing head size and global developmental delay, motor more than a cognitive delay.
Okay. So child was on VP shunt since age of three months. So long, so long course of VP shunting. And here we have the MR images. So here on the MR, you can appreciate that there is an extra-axial lesion, a well-circumscribed extra-axial lesion in the left cerebral hemisphere. It is pushing the brain towards the right side. You can appreciate there is some areas of heterogeneity and another roundish lesion within the external lesion. The lesion demonstrates restricted diffusion. Areas of restriction within the central lesion. On the SWI, the peripheral rim demonstrates blooming and also the subdural space along the right convexity. There is also cerebellar and brainstem atrophy. This is likely due to the long-standing hydrocephalic changes. And also the gyral pattern is abnormal. It's a dysgyric or a stenogyric pattern where there is the gyri are closely opposed to each other, but there's no thickening or dysplastic appearance. Contrast study was done. The lesion, the extra-axial lesion, does not demonstrate any enhancement. Some thin areas of peripheral enhancement are seen. Subdural collections demonstrate enhancement, but this is commonly seen in the chronic subdural collections. There's also hyperostosis of the skull. Again, can be compensatory or reactionary due to the long-standing hydrocephalus. CT was done, and on CT you can appreciate that there is a well-walled-off lesion in the extra-axial space on the left side. Subdural hematoma on the right. No internal calcification or hemorrhage within this lesion. So we have a diagnosis, but at this point, probably I have to open this case for any further comments. If anyone has seen such a presentation of a long-standing hydrocephalus on VP shunt.
No, I think it's really weird. Never seen anything like it.
Yeah, this child was managed in Africa. This family is from African background. And this is the first visit to us at 3 years of age with this MRI. They had come for the surgical intervention.
So a biopsy was done, and the biopsy demonstrated the comments were there. It's a large cyst. It's a benign cyst with calcification and hemorrhage. An Arachnoid cyst is a likely possibility. So the lesion is a benign cyst, and what we think with calcification and hemorrhage, and what we think the possibility is a giant calcified hematoma within the subdural space. These can be seen rarely in a long-term complication for patients with shunted hydrocephalus. So there are a few case reports presenting with similar imaging and clinical pattern as seen in our case.
Could you see the images before he was shunted? Like before 3 months of age? Was this any cyst there or any congenital arachnoid cyst which was?
No, actually these are done externally, and they showed the images after we got the biopsy result. So I have not seen the initial scans.
Okay.
We just wanted to show this case because it was, yeah. So such a remarkable presentation. It's pretty rare, so just wanted to show this case.
So what did the surgeons have removed this or drained it? What have they done? Like,
Dr. Lokesh?
Craniotomy and excision, evacuation of the subdural hematoma was transferred.
Okay, so we'll move to our next case. Case 8 is was initially seen by Dr. Pradeep Kalolimat and was sent to Dr. Lokesh. So it's a 7-year female born to consanguineous parents, the only child, had normal delivery, but history of birth asphyxia. There's an ICU stay for 2 days. Child has global developmental delay. At this age, he speaks only in bisyllables. Has not achieved toilet training. Patients have observed abnormal eye movements since early childhood. On examination, child has dysmorphic facies, dystonia, nystagmus, and ataxia. No seizures and no involuntary movements. We have videos of the child if Dr. Lokesh or one of the clinicians can demonstrate the findings. I think there are some nystagmus changes.
Microcephaly with brachycephaly.
Yeah.
I think she was ambulant only by sitting. That's what Dr. Pradeep had mentioned. And cognition was slightly better than her motor abilities. Understanding and recognition of family members were there, and nystagmus was also noted by Dr. Pradeep.
So the imaging, we have the MR brains. On top is the axial sequences. There's obviously some abnormality, some mild abnormality in the shape of the skull, but I cannot appreciate any synesthetic or overriding of the sutures that will be difficult on the MR. No cortical malformations, no focal lesions. The basal ganglia are slightly, they demonstrate like gliosis or reduction in volume. Thalamus demonstrates normal appearance. But the main findings are in the posterior fossa. You can appreciate that there is dysplastic appearance of the cerebellum. There is also hypoplasia of the brainstem, in particular the pons. The corpus callosum is also hypogenetic. You can appreciate that the vermis is also reduced in height and also demonstrates dysplastic appearance. If you see here closely, you can appreciate that there are some areas of tiny cysts around the periphery, predominantly in the bilateral inferior cerebellar hemispheres. So at this stage, the main findings are pontocerebellar hypoplasia with cerebellar dysplasia, tiny microcysts, some degree of volume loss in the basal ganglia on both sides, no cortical malformations, no white matter lesions in the supratemporal brain. So differentials are wide. I could not narrow it down to a particular diagnosis, but these are papers from John Hopkins, also Dr. Bolthauser has been part of them. So the conditions of cerebellar dysplasia with cysts, one can think of alpha dystonia retinopathies or CMDs. Polity-Bolthauser syndrome, GPRS, or Col3A mutations have other additional features such as cortical malformations. Polity-Bolthauser syndrome has myopia. Microcephaly is a less likely feature. Chudley-Macular syndrome should have hearing loss and also areas of heterotopia, which are not seen in our case, and they also have partial corpusculosum agenesis. Tubulopathies, again, the basic angular changes are not typical of tubulopathies, and also the brainstem is slightly asymmetrical on the axil, which is not seen in our case. Joubert, again, I could not appreciate any molar tooth appearance or mild molar tooth appearance, which is commonly seen in the Jouberts. This is again a pattern approach for the posterior fossa malformations. Again, the conditions which we have covered are listed over here. This is another paper from Dr. Bolthauser for the pattern recognition approach of pontocerebellar hypoplasias. Supratemporal abnormalities, the reduced brainstem, the basic angular volume, I think, could be secondary to hypoxic changes, but could not narrow it down to a particular diagnosis. So at this moment, I'll open it up for the panel. The clinical RAD association and possible diagnosis.
I don't have anything to add.
Okay.
We need genetics to clarify further.
I showed it to Aigen and yeah, Aigen, please go ahead.
Brief comment. The case you have shown does not fit to any of the entities you have listed in the tables. And just because of LAMA1 mutations, Poretti-Bolshauser syndrome, the patients we know now, about 30 patients, they are not microcephalic. They reach the ability to stand and walk, maybe a little bit late, but not terribly late. Cognition is rather well. They have speech, they attend school, perhaps with some support. So this is the clinical context does not fit to this girl. So this is perhaps a kind of a new entity, and the genetic testing may give a result or not.
Thank you, Prof. That was very helpful.
Again, you had commented on a possible association of ISPD, but I think
ISPD
again,
mutations can mimic ISPD gene mutation can mimic LAMA1 mutations. I've seen 2 siblings with this, but they had highly elevated CK and also proximal muscle weakness, and they were ambulant. So this is this does not fit to this clinical context, and I guess this mutation would come out in a exome sequencing.
Okay. Well, thank you. Hopefully, we can get a diagnosis. Next case is from Dr. Kavita. If Sahil is there, you can present the case.
Yes, sir. This is a 4-month-old male child born of first issue of non-consanguineous marriage, full term normal vaginal delivery. On day of life 4, he had a persistence of neonatal seizures. He had bilateral tonic posturing of all 4 limbs followed by uprolling of eyeballs, which lasted for 1 to 2 minutes. So on examination, there was definitely global developmental delay. Head circumference was with 3 to 50th centile. On tone, there was spasticity with brisk reflexes, and I had an opistotonic posturing and roving eye movements also. So since he had seizures, we did an EEG, which showed multifocal epileptiform discharges more in the left temporal region. So after that, we went for an MRI. So the MRI was done, and
so the quality of the image is not great, but this MRI was done at what age, Sahil?
this was done at around 3 months of age, sir.
Okay, I cannot. Yeah, these are the 2 images I have, but I cannot appreciate any abnormalities. But given the quality, I do no significant findings is what I can say, at least on these images.
Yes. Yes.
And the follow-up MRI was done because of
he had a dystonic posturing, sir, continuously dystonic posturing with seizure activity, and EEG also showed focal discharges in the left temporal region also. So that's why we went ahead and did an MRI. Yes, sir.
So after this MRI.
Good evening, everyone. EEG showed a very bad, epileptic encephalopathy kind of picture, very frequent multifocal discharges coming from both the hemispheres. And this MRI was done at the age of 3 months, but it was not of very good quality. And this baby had started with the seizures in the neonatal period, but after that there was a quiet period. And since last 2 months, he was having almost very frequent these episodes of ophistotonus and almost oculogyric crisis kind of movements. So we were actually thinking of neurotransmitter disorders and on genetic lines. But we just thought that because this is a poor quality MRI, let us at least rule out any structural malformation first, and then we will go on to the other investigation. So that's why we repeated this MRI. Yeah. You can show the current MRI. Am I audible? Hello?
Yeah, audible, Dr. Kavita.
So this old MRI was supposed to be normal. It was not showing anything much. And though I felt there was a little chinking of the lateral ventricles. Dr. Nihaal?
Yeah, Dr. Kavita. Sorry, I think I lost you.
Yeah, you can go ahead with the current MRI. This is really of good quality.
Yeah. So this is a follow-up MRI, and on the follow-up MRI, you can appreciate that there is ventriculomegaly, supratental ventriculomegaly. Cannot find any focal lesions, but the ventricles and the third ventricle are dilated. There's also some rounding of the temporal horns, but no significant periventricular interstitial edema, at least on the flare images. Or on the diffusion, you can appreciate there's some areas of periventricular flaring, so there's some areas of interstitial edema. No diffusion changes within the ventricles or the extraxal spaces. No focal abnormalities. Posterior fossa also, I cannot appreciate any signal changes on the DWI sequences. So we have the contrast MR done, and on the contrast, Again, no focal abnormalities. I think it was commented or as leptomeningeal enhancement, but I think these changes are normal vascular enhancement of the normal vessels in the sulcus, leptomeninges. No enhancement in the basal cisterns. No ventriculitis or evidence of ventriculitis on imaging. On the sagittal images, you can appreciate that there is this focal narrowing at the inferior aspect of the aqueduct. So this is the likely cause of the hydrocephalus. Post-contrast sagittal and again post-contrast coronary images, you can appreciate the supratentorial ventriculomegaly. Fourth ventricle demonstrates normal appearance. The likely cause is an obstruction at the level of the aqueduct of Sylvius. So the clinical question, what was the dilemma, Dr. Kavita?
Yeah, so we did a CSF because this was reported as a leptomeningeal enhancement. So we did a CSF and it did show high proteins around 205 with the just borderline sugars, and the cells were I think 100, which were
Yes,
more of lymphocytes.
more of lymphocytic predominant.
Like
Yes,
a chronic meningitis, yeah. Though the CSF, which was documented at birth because he had some seizures, was also showing mildly raised proteins, 70, though it is still in the borderline for a newborn. So for full term baby, 70 I thought was a little highish, but it was not treated with any antibiotics or no other cultures or anything was sent. So the only thing is that the MRI at I think 2 or 3 months at that age it was done and it did not show anything much. And then now there is already a hydrocephalus with a chronic meningitis kind of a picture. So we were really surprised because we were planning for a genetic study and this was completely unexpected. So I just wanted to discuss.
Does the hydrocephalus explain the dystonia and other features?
Yeah, actually the movements were very unusual. They look more like neurotransmitter disorder to me. Even on just a little bit touch, the child would go into complete opisthotonus. I mean, it can happen in raised ICP, but with the oculogyric movements and this thing, it was really very unusual. But as of now, for this, because of the CSF finding and all, I was still thinking of maybe Icadi Gutier and all. They can have increased proteins and you can still have a very bad epileptic encephalopathy also going on. But they didn't find any calcifications, at least in the SWI images. So I really don't know whether to really go on the line of chronic meningitis, and once the protein settles down, then we'll plan a BP shunt, or should I still do some genetic studies? I'm not really sure. The movements are the same. I mean, we have just started the antibiotic 1 week back. So any comments from others? I mean,
I think what I think is between both scans, I think the child has developed infection, and the infection has caused obstructive hydrocephalus with some adhesions or septation at the level of the aqueduct. That I think is not related to the initial presentation of the child because the child had symptoms before we saw the hydrocephalus. So at least I think it can still be a genetic possibility, but I think the hydrocephalus is probably not related to the genetic condition.
And classically, when we see kids with hydrocephalus, usually they come with bulging AF and having sun setting and all those things. Of course, with the open AF, we may not get it, but this presentation is very unusual to have such kind of very frequent opistotonic episodes and these oculogyric movements. So maybe it is not related to the hydrocephalus and there is some other genetic cause to it. That's what was our question.
So the question from Dr. Prasad, anything in the abdomen and the spine? It was done.
Sorry?
Any focus of infection in the abdomen?
Normal. There was mild hepatomegaly, like 1 to 2 centimeter palpable, but liver functions are normal and it's not like a very firm abnormal liver.
Okay.
I just had a question. Have you tried pyridoxine, Dr. Kavita? Because they can have this seizure since birth, irritability, abnormal, and even hydrocephalus has been reported, I think.
Voice is not coming very clear. Tried what?
Pyridoxine. Have you tried?
Pyridoxine.
Yeah.
We had, actually they already came with a cocktail already started outside. So in fact, there was hardly any anti-epileptic left if they had not tried outside. And when they came to us, then I was just trying to rule out any significant malformation because of the poor quality MRI, and I was totally not expecting this to be a chronic meningitis. And they were already started on all the cocktail outside, which I had continued. And when I got this meningitis thing, then I discontinued all the cocktail. It still didn't make any worse, you know. So it didn't help at all.
Okay.
Yeah.
Because I think still genetic is a strong possibility. He had seizures since birth. That is not explained by any
Agreed.
chronic meningitis. So
what I feel that he may be having meningitis at that point of time, and then it has, you know, persisted in a low grade kind of thing with causing adhesions and hydrocephalus. But even then, all the movements are very difficult to explain. Maybe if after the full course of antibiotics, if they subside, then still once we treat the hydrocephalus and if they subside, then only we can say that this was the cause for that.
So was it a ventricular CSF or a lumbar CSF? And what was the sugar?
No, lumbar only. Lumbar is abnormal. Lumbar is a
lumbar CSF with aqueductal stenosis.
Sorry?
You're brave to do a lumbar CSF with aqueductal stenosis, even though the fontanelle is open, but it was a bit risky. So you didn't do a ventricular tap?
No, we didn't do, because we got abnormality in the lumbar itself. No? There is high protein and cells are also high. So there is definitely meningitis. So we have not done a ventricular tap.
Sugars
are borderline. So that may be, as you said, because of,
Because mostly what happens is you have this improperly or untreated meningitis, and then you have ventriculitis, which causes the hydrocephalus and aqueductal stenosis. So ventricular tap will be important.
Okay. Because I got this thing CSF abnormal, then I didn't go for ventriculitis.
Even though I should say the ventricular margins are enhanced on this contrast. Nihaal, are the ventricular margins enhanced?
No, they don't. They also don't demonstrate any restricted diffusion, which can be seen in ventriculitis. This is more of a chronic subacute
not
picture.
even sure about meningitis, right? Sorry.
Yeah.
But diffusion restriction is not necessary in ventriculitis anyhow. So one should always do a ventricular. I feel ventricular tap should be done. You might miss it on imaging because that will give the logic. You know, if you have got aqueductal inflammation with hydrocephalus, with CSF in lumbar area showing it, the ventricular tap should help.
Okay. We can plan that, of course, and maybe it will yield an organism also, which we may not get in the lumbar CS. But the only thing why I wanted to present this is maybe we'll have a follow-up MRI later and see whether this improves or not.
And were there seizures or were they just tonic posturings in the neonatal period, which were thought to be seizures?
We are not sure what kind of movements they were. Mostly there was probably just tonic posturing, because there was also uprolling of eyeballs, as the mother said. But of course, we are not sure about it.
Okay.
Because nothing was documented in this thing, just neonatal seizures, history of neonatal seizures is written like that in the card.
Yeah, in infants with unexplained hydrocephalus, it's always a good idea to do a ventricular tap before doing the surgical intervention. Many times this occurred, as Vivek highlighted. The ventriculitis is the etiology for the hydrocephalus, and once you put a shunt and there is a foreign body, even more difficult to treat. So the explained hydrocephalus, especially somebody who has spent some time in NICU, it's always a good idea to do a ventricular tap before the surgical intervention.
Agreed. So we are not planning for we are not planning for an immediate BP shunt till we get the proteins controlled. Definitely.
But you should keep in a Omaya because your tap might at least help you to decrease the dystonic posturing.
Okay. Even like by decompressing. Fine.
Yeah.
Okay. Sorry.
Okay.
Thank you. Thanks. Thank you, everyone.
Yeah. Thanks. The next case is from Dr. Nikit. If Dr. Nikit is there, you can.
Yeah, I'm.
Yeah.
Sorry. About the disturbance. Is a 5.5-year-old child who presented with regression of motor milestones predominantly. from last 8 months. He was previously normal cognitively and motor-wise, and had some on examination has a spastic paraparesis. There was also some history of very myoclonic jerks, not very convincing, but there was a single right focal non-motor seizure, and there was an incidentally detected left parietal granuloma. And the scans you can discuss, Nihaal.
Okay, sure, thank you. So these are the initial scans done in July 2021. These are external scans. On the left is the T1 non-contrast sequences. I think the quality is not optimal, but so here what you can appreciate that there's T1 hyperintensities along the bilateral basal ganglia, more around the globopallidi. And also, if you see on the top, the midbrain is abnormal, demonstrating these hyperintense changes. The dorsal pons are also demonstrating changes. The ventral pons or the pontine belly is normal in signal changes. The cerebellar white matter and the dentate nuclei also demonstrate T1 hyperintensities. And also, if you think for a 5.5-year-old child, the white matter is slightly hyperintense than what we see normally for a child at this age. And on the post-contrast, again, the hyperintense changes, they do not demonstrate any contrast enhancement, but you can appreciate them. And we have this focus of ring enhancing lesion in the left superior parietal lobule. On the sagittal images, again, not very optimal, but you can see that there is a sparing of the pontine belly in terms of the signal changes on the T1 weighted scans. So based on this, I think the child was treated for NCC. Am I right, Dr. Nikit? Was that the
Yeah. So he was treated for NCC, but other changes were not reported wherever the scan was done. They had reported everything else apart from granuloma is absolutely normal. So these changes were not picked up at all, and they came with a progressive deteriorating motor abilities up to the mark where he is completely immobile over a period of 8 months, and he is not even able to maintain sitting posture on his own.
Okay.
And then because these changes were there, I think we got another scan because some of the sequence and other things which weren't very clear on the given imaging. To clarify all the doubts, we asked for another imaging. And that when I think Nihaal, you can show that.
Yeah, so this was done, I think, a couple of days back. And you can appreciate this is a T1 non-contrast axial sequences. Again, the white matter is diffusely demonstrating hyperintense signal changes. The basal ganglia also is hyperintense. The thalamus is relatively isointense in comparison to the rest of the white matter and the basal ganglia. You can also appreciate the changes in the midbrain, some sparing of the red nuclei on both sides. The dorsal pons also demonstrates these hyperintense signal changes. Sorry. And also the cerebellar white matter, that is the dentate nucleus, demonstrate T1 hyperintensities. Corresponding T2 low signal changes were only seen in the bilateral globopallida and the cerebral peduncles. Coming to the SWR sequences, there is some abnormal mineralization for a 5.5-year-old child in the bilateral globopallidi and also in the substantia nigra. The rest of the white matter and the cerebellum does not demonstrate any blooming foci. And on the sagittal images, what you can appreciate is that there is this sparing of the pons, whereas the dorsal brainstem dorsal pons is involved, demonstrating T1 hyperintensities. The midbrain demonstrates hyperintensities. Corpus callosum is also slightly hyperintense. The pituitary gland also, the anterior gland also demonstrates these hyperintense changes, which should not be seen on a normal T1 non-contrast sequence. And the granuloma has now almost completely resolved. So here is the residual focal granuloma. We did a CT scan and this did not show any calcification, but yeah, you can see that the size has come down. So based on these findings, we thought of a possibility of manganese-related disorders. So they have characteristic appearance of hyperintense signal changes within the DBA nuclei, but also the white matter demonstrates these size signal changes. And this is actually a paper from Dr. Suhasini, which also demonstrates similar imaging findings which are seen in our index case. The differentials were NBIA, but I think the white matter does not demonstrate these high signal changes on the NBIA spectrum of disorders. And Wilson's also was another differential, clinical differential, but I think they usually have high signal changes on the T2 and the phase sequences, which are not seen in our case. So if Dr. Suhasini wants to comment on the findings, if they match with her recently published case series.
Yeah, I think I mean, that was the first thing which came to my mind when I saw the MRI. Only thing is clinical presentation, I sounded a little odd, like I've never seen myoclonic seizures.
Yeah. Yeah, probably myoclonic seizure wasn't really convincing, Dr. Suhasini. Okay. But before looking at the images, I think as a standard of this thing I was asking about and demonstrated, but they were saying the other odd presentation about the clinical thing is presented as a spastic diplegia, though we did not have previous videos of in previous few months where he was walking, so we couldn't clearly comment upon the gait. But it's more like a spastic diplegia with complete normal upper limb examination, which is slightly odd for manganese transporter diffusion.
Yeah, lower limbs are involved more than upper limbs. That's all right. That's all right. The seizures, I don't. Seizures also now being.
Seizure, I mean. Yeah, seizures were not. I mean, I wasn't really impressed or convinced with that history of myoclonic jerk. But I think that is what they were mentioning. That is really very odd. I've asked for manganese levels, but with some confusion, who sir build it? Probably they build it as a magnesium, so we lost actually couple of days.
We're getting it done tomorrow.
Yeah. So we will get the results tomorrow. Yeah.
Do you have an EEG?
No, we haven't done EEG actually. So
and CBC and liver examination?
Yeah, so liver functions and INR I did. Liver function and INR is completely normal. I haven't done CBC. There were some previous blood counts and things from other hospitals. Those were, I think, 6-7 months back. And they were not demonstrating any polycythemia.
Could be the SLC 39
Yeah. So one of those variants where probably I think we do not have any of the other corroborative markers.
So just one thing I wanted to ask is the seizure could be probably because of the granuloma or even he had focal seizures as well, right? That is definite.
Yeah, he had that. He had focal seizure that can go with the focal. I mean the left parietal granuloma. He had a right focal seizure. But the myoclonic jerks, I'm not really very sure about. Maybe next time when they come, we'll get the EEG done. But I saw him almost for half an hour in the clinic room, but he never demonstrated any myoclonic jerks as such. And what they were saying is they're spaced throughout the day. They are not specific time bound or anything. So I'm not really sure about it, but maybe it would be a good idea to do an EEG when it comes for next follow-up.
And because now a few case reports of epilepsy have also been reported with, and even in our series 2-3 patients had seizures. So I don't know if the granuloma was incidental or it just caused a seizure. So that's what's interesting.
Yeah, sure. Okay, thank you. Maybe yeah, we'll ask for EEG when they come back.
Yeah.
Okay, thank you.
There are no further comments. We'll move on to our next case. So Dr. Ramesh, I don't think he's here, but so it's a child with a 4-year-old female with motor developmental delay, static in course, had cerebellar signs in the form of appendicular more than axial changes, hypotonia, bilateral esotropia, normal cognition. Was born to 4-degree consanguineous marriage, full-term child, the birth weight of 2.3 kgs, and NSU stay for 4 days for respiratory distress. So this is another proven case which we have, and on the images, the external scans, you can appreciate that there are some degree of volume loss in the superficial frontoparietal regions. The deep gray nuclei demonstrate normal appearance, but the main finding is in the cerebellar brain parenchyma, that is demonstrate the vermis and the cerebellar hemispheres demonstrate isolated cerebellar atrophy. Brainstem is normal. So as discussed in our previous case, the finding is not specific. But since we had a confirmed diagnosis, just wanted to show this case. So the child had a variant of uncertain significance for GRM1 gene. The mother, the parents and the siblings were tested, and both had all three had the genes present but were asymptomatic. So again, going back to our pattern approach, again the paper from Dr. Bolthager, where we have the gene listed in the pure cerebellar atrophy pattern. It causes spinocerebellar ataxia 44 or the autosomal recessive 13 type. If anyone has any experience with this case or gene, we'd like to hear comments. Thanks.
I have a question. Can you go back one slide?
The gene or the images?
This one, yes, please. So this is mother, father, and a sibling, but this is not the patient. This is not the index patient. Is it?
No, the index patient had. So the index patient had a GRM1 gene. So that was a variant of uncertain significance.
On both alleles.
So the yes.
Can you go?
So the parents, yeah.
Okay. Can you go back one slide?
To the imaging?
Yeah. Just a personal comment. It's about semantics. If you have one shot, one MR at 4 years, I think it's better to call this just descriptive as enlarged fissures, because you don't know, is this a residual situation following the cerebellitis? Is it congenital or is it progressive? And in terms of the history of this patient, who has already since early infancy a delay, you think this is likely a congenital situation. Some people call this hypoplasia. You can discuss whether this is meaningful, but it's just opposite to a, say, progressive cerebellar atrophy like you see in Lewy Body syndrome and so on. So there are now a number of genes are known in the meantime who are associated with congenital non-progressive ataxia and this kind of image. The list is about 15 genes. And of course, you cannot make the diagnosis just from this MR. So you need additional genetic confirmation. The puzzling thing is, and this is well documented for ITPR1 gene, a dominant gene, that this is a stable situation on the long run, while the MR can get worse over time. So an additional cerebellar volume loss is not necessarily meaning that you lose also clinical skills. I hope this was confusing enough.
No, it's clear. I just wanted to add, I think there is some focal thinning of the cervical cord, especially in the cervicomedullary region. If that is part of the spinocerebellar ataxia, or given the LSCS delivery, if there was some injury over there. Does that explain the motor issue, or is the cerebellar changes enough to explain the motor developmental delay?
I'm not sure whether this finding does explain anything. I mean, you have ample of CSF around. This is there is no code compression.
Nihaal, can you comment on a sagittal brain MRI on a cervical cord, because you often see that sort of apparent thinning, because you need a cervical proper image, right?
Yes.
Yes, the axial and the sagittal.
Cervical cord thinning, just as a repetition with cerebellar atrophy, would point to RSACs, for example, autosomal recessive spastic ataxia of Charlevoix-Saguenin, which is of course rare. In this situation, you have hypointense stripes in the brainstem on FLAIR and D2. And but as a rule, for example, Friedreich ataxia, who goes along with the cervical cord thinning, initially has a normal cerebellum. So this image is not compatible with early stage of Friedreich ataxia in my mind.
And again, is that right that in ARCAX you will have that Pons specific stripes where
the tiger stripe pattern?
Yeah, that's missing. Yeah.
So do you not think the gene is contributory, the GRM1 gene of the condition?
As far as I know, this GRM1 gene has been repeatedly associated with congenital ataxia. And by the way, I've seen a paper a few years ago. This was a founder mutation in Bulgaria in a Roma population. Just by the way, there are other founder mutations. Yeah.
Okay. Thank you.
Good evening. This is Dr. Prerna. So I just wanted to know, would you recommend subsequent imaging to see how it progresses, so that to understand whether it matches the genotype or not, or would you just go by?
You mean in this particular patient or in general?
In this particular patient, because this is a single scan and we are unable to say whether it is hyperplasia or atrophy because it is just a single scan. And keeping in mind the genetic testing that we have, which is suggestive of a progressive condition.
In my interpretation, of course, with limited experience, the clinical situation, the history, the gene finding, and the image fit very well to this GRM1 associated congenital ataxia.
Okay, okay, sir. Thank you.
If you don't have new aspect, I think repeat imaging is not necessary.
Okay, sir. Thank you.
Okay, thank you. Going on to our last case. It's an 8-month-old male born to third-degree consanguineous.
Good evening, sir.
Yeah.
Good evening, sir. This is Sudhi. I'll present this one.
Yeah.
So this one was an 8-month-old male child born to third-degree consanguinity. They had come at 8 months of age with the complaints of developmental delay and refractory epilepsy. The child was fine till 4 months of age. He had attained social smile, though no neck holding was there. But then he started becoming more irritable, and there was some skin condition in the form of eczematic skin, which was there since birth, but it started worsening after 5th month of age. So there were more and more of eczema and scaly appearance of the skin. The child became more and more irritable, and thereafter he did not attain any motor milestones, and even the social smile also regressed. And he started developing epilepsy from 6 months of age. The seizures were more of GDCS only, so they were not focal, they were not myoclonic, multifocal, or GDCS. They did not have the videos, and it was refractory. So they had to write 2-3 medications before they came to us, and after coming to us also, we started some medications, but did not help. Looking at the clinical picture and the MRI pictures, we were thinking of biotinidase deficiency. And PMS with biotinidase levels, the investigations were normal. So wanted to discuss the differentials for them.
Okay. So we have an MR and the CT done. From the MR images, you can appreciate that there's bilateral subdural collections and also some areas of necrosis or cavitations in the bilateral basal ganglia. These changes demonstrate blooming on the SWR sequences with no corresponding areas of calcification, suggestive of a bleed. There is some intraventricular hemorrhage in the bilateral ventricles, some degree of volume loss in the supratemporal brain parenchyma. The posterior fossa structures demonstrate no signal abnormalities or volume changes. There is thinning of the corpus callosum and some microhemorrhagic foci in the left occipital region and also in the fourth ventricle. CT was done. I think there are some tiny foci of hyperdensities, probably calcifications, but the rest of the blooming foci do not correspond with any calcification. So cavitatory lesion in the bilateral basal ganglia with a mixture of calcification and hemorrhage, old hemocytin deposits, bilateral subdural collections. I could not appreciate any tortuous vessels within the, at least the non-MRA scans. And yeah, so those are the findings. Clinically, I think pituitary deficiency was thought of, which has been, I think, ruled out now. Menkes disease was another clinical differentials which based on the clinical findings, and these are other differentials which can present with the combination of the clinical findings. Subdural collections on imaging, at least these are the main differentials. Glutamic aciduria can be ruled out. Menkes did not have the arterial abnormalities but had the subdural collections and the basal ganglia changes which can be seen in Menkes. No history of abusive hand injury or rickets. Biotinidase deficiency again can have bilateral subdural collections because of the progressive volume loss. As Menkes was one of the clinical differentials, so these are the imaging findings of Menkes disease. They can present with subdural collections, bilateral basal ganglia infarcts, cerebral and cerebellar atrophy can be seen, and focal white matter lesions with abnormal myelination can also be demonstrated. And obviously, the increased intracranial arterial tortuosity can also be characteristic or suggestive of a Menkes disease. Biotinidase deficiency can present with subdural collections, but I could not find any cases or literature with basal ganglia abnormalities and intraventricular or hemorrhagic changes. So overall white matter changes can be seen with progressive volume loss and subdural collections. Also thought of a possibility of COL4A12 mutation based on the central changes of cavitation, hemocytin, and calcification. Icardiogutrase with the ADR1 mutation can also demonstrate these basal ganglia changes. And I think one has to rule out the causes of neonatal intracranial hemorrhage. Was the child a preterm child, Surabhi?
No, was a full-term child, sir. There were no perinatal issues. It was well till 4 months.
Okay. So yeah, at this moment, I'll open the case for any further comments.
Do we have a genetic diagnosis? Has it been?
I don't think so.
No, we haven't sent it yet. No.
I agree. Clinically, at least biotinidase seems very high on the list, looking at the clinical picture.
Also, we tried biotin, but the epilepsy was not responding to it, so that was another clue that it was not biotin detecting. And of course, the report came normal.
Are we sending them for the whole exam?
We're planning to censor, but just thinking of narrowing down the differentials. Menkes was, yes, another possibility, but as you say, there are no tortuosities, so we're not giving a lot of clues.
Is icardiogutrase possible? Those subdural collections, I think, can be seen in the other mutations, at least on the clinical findings.
They can also have rash, but I don't know about atopic dermatitis.
Yeah.
There were not much of extrapyramidal signs. Epilepsy maybe can be there, but there were no significant tonal abnormalities, and the skin changes were a little odd.
Complex case. Any other comments? Okay, if there are no further comments, we'll probably try and get a follow-up and discuss them in the next following sessions. I just have 2 follow-up cases which are discussed previously. We'll just quickly go through them. We have a confirmed diagnosis. This was presented in, I think, was in November end or December at the December meetings. This is a 5-year-old male with cognitive and motor regression. Had gradual onset myoclonic epilepsy with dystonia, gait ataxia, and had excessive startles. There was developmental regression following seizure at the age of 4 years, and also there was a history of sibling deaths. The imaging demonstrated this confluent demyelinating leukodystrophy type pattern. involving the bilateral cerebral hemispheres, also the central white matter and the cerebellar white matter. Some changes in the brainstem, thinning of the corpus callosum. There's some darkening of the thalamus on both sides. So at that point, we thought of a possibility of a lysosomal storage disorder, the leukodystrophy under the demyelinating spectrum. MLD, Krabbe's, gangliosidosis were given as the possibilities. And on genetics, we got a likely pathogenic variant for metachromatic leukodystrophy. And I'll just show the second case, and then we can take any comments if needed. Then we have a follow-up case which was discussed on December 30th, I think, and this was a 6-year-old with developmental delay, horizontal VS palsy, bilateral adduction issues, adductive nystagmus, and hypotonia. And these were the MR images. Supratentorial was unremarkable, whereas the primary changes were in the brainstem. You can appreciate this split pons appearance and also this butterfly appearance of the medulla. So at that point, we had suggested a possibility of a ROBO3 mutation. And on the genetics, we got a variant of uncertain significance, but I think the clinical and the imaging phenotype matches with the ROBO3 mutation. So these are two worked up cases, and I think that should end our session. If there are any further comments, we would like to take them.
This image is so classical. You don't, of course, whether it doesn't matter whether this variant is of unknown significance. This image is just diagnostic.
Yes, thanks, Evin.
Thank you. Thank you.
This, we are over time. We are over time. Or can I make a short comment?
Yeah, short. Yeah, it's fine.
ROBO3 is an axonal guidance disorder, and all tracts do not cross, in contrast to Joubert syndrome, where only a few tracts do not cross. Joubert syndrome has, as a rule, no scoliosis, and the explanation in ROBO3 is that you develop scoliosis because motor and sensory tracts do not cross. Maybe it's not correct, but it's the best explanation.
Yeah. Yep. Yes. Thanks again.
Thank you.
So yeah, thank you everyone. Our next session will be on 25th February, and yeah,